Today, in this Ask the Author session, I have the great pleasure to host Professor Stefano Romeo, who will discuss with us a recent publication on data-driven cluster analysis identifies distinct types of metabolic dysfunction-associated steatotic liver disease. Thank you very much, Stefano, to be with us today. Congratulations for this great paper. As you know, the nomenclature changed. We went away from the N of non-alcoholic to the M of metabolic, which was a great change because it's a positive definition of the disease, which allowed also to have a new class related to the overlap with alcohol. Nevertheless, if we think about the metabolic aspect, this is still a broad bag, and many patients are in it, and I'm not surprised that actually you went on to try to define subtypes. But the way you did it is extremely interesting. I would like you explain the design of your study.
Thank you very much, Jean-Francois, and thank you for inviting me. It's my pleasure to be here today. So the idea was to try to find through and look through the heterogeneity of the disease. So we see clinically some people living with muscle that have an aggressive liver disease, but they do not develop cardiovascular disease, while there are others that have a milder liver disease and yet progress into cardiovascular events in a more aggressive way. So we try to, so the idea was to understand this heterogeneity. And so how do we do that? We started by a simple clustering using 6 easy variables available in every clinic: HbA1c, triglyceride, LDL, age, BMI, and ALT. So then this is unsupervised. So we asked the machine to create clusters. Then it came out with 3 clusters. 2 of them had evidence at the liver histology of having muscle, and 1 didn't. So they look similar at a liver level. But then when we look at the clusters, there were different things. So 1 cluster had higher triglycerides and higher HbA1c, indicating more dyslipidemia and diabetes. The other one was having increased in ALT, so indicating a more specific liver disease. So we thought to look at the prospective data in the UK Biobank. So the first part was done in bariatric surgery cohorts. So there was this bias whether it would work out in obese in general population level. So we went in the UK Biobank, we replicated the clusters, and we could see that indeed the cluster with triglycerides and HbA1c had more cardiovascular events, while the cluster with ALT that was increased didn't have increase in cardiovascular event. And the same was for diabetes. The cluster with HbA1c had a much larger risk of diabetes, while the one with ALT, basically, he had mostly liver-related events. And so this suggests that, in a way, muscle or liver triglycerides is a phenotype. You can think about blood glucose and type 1 and type 2 diabetes. So the increase in glucose is the same, no difference if you have elevated. But then, of course, when you look at the phenotype, you see that they are completely different and they are driven by different pathological mechanisms.
Yes, I really like the glucose analogy and the diabetes type 1 and type 2. And now I think you even can go a little bit further because you had another paper on this, showing a kind of a causality between the liver disease and
Yes.
cardiovascular events.
So if you had told me before this paper or before looking at the data, if muscle was causally associated with cardiovascular events, heart failure, hypertension, I would said absolutely not. So we had these data and a bunch of SNP after a genome-wide association study. And then we had this idea to create 2 polygenic risk scores. And how did we do that? We just selected the one group, that the one based on the mechanisms of one of the genes that is most known to affect fatty liver disease. TM6SF2 and PMPLA3, in which you have a lipoprotein retention. So triglycerides are retained in the liver triglycerides increase, but the lipoprotein decrease. So these people have higher MASH, fibrosis, cancer, but lower risk of cardiovascular disease. I mean, PLA3 is neutral, but TM6 is very protective. And so the idea was, okay, we know this. What happened for the other one? So the group in which we don't have the lipoprotein retention. So supposedly, allegedly, increase in lipogenesis, increase in substrate to the liver. We don't know that yet. And so when we did these two, we found that the one with TM6 and PMPLA3 had an increase in liver disease and protected against cardiovascular disease, no association whatsoever with hypertension, heart failure, kidney failure. And the surprise came with the other one. So the other one was associated with the entire spectrum of the cardiorenal metabolic syndrome. And this was a big surprise. And taken together with the other paper that actually started with very different premises, it was kind of like looking at each other in the mirror, two different methods showing similar things, that the existence or of one type of muscle that is more liver specific, in which the liver is mostly affected, and probably because of some liver specific mechanism, and the other one in which the entire body is affected. We call it systemic muscle. And that was the big surprise. I really couldn't believe what I was looking at, and obviously very excited. Probably the most exciting work of my life as a senior investigator or independent investigator.
Well, I mean, really exciting effectively, because you really differentiate these two phenotypes, these two diseases actually with different trajectories, and you will change the way we are actually managing these patients. So thank you very much for taking the time to explain us this. Thank you, Professor Romeo, and all good.
Absolutely. Anytime. Bye.